Hi, my name is Rick Alleman. I'm a clinical pathologist at the University of Florida College of Veterinary Medicine, and I'm here to talk to you about the topic of veterinary hematology. Now, today's session is going to be called Veterinary Hematology: Significant Findings in the Peripheral Blood. And it's intended to be a review of the findings that we can incorporate into our clinical data when evaluating patients in our hospital. In addition to that, and in addition to it being a review for you, I would also like you to gain two other valuable bits of information here. One is a technique on how to systematically evaluate the peripheral blood smear. And in addition to that, I would also like for you to gain a practical knowledge of the valuable information that can be gained from evaluation of a peripheral blood smear, so that you can use this tool, in addition to helping you with the exam, you can use this tool to the fullest extent in your daily practice of veterinary medicine. So let's go ahead and get started. The first thing we'll talk about is slide preparation. Once you've collected your peripheral blood smear, peripheral blood, and you have it in your EDTA tube, we want to prepare your slide. Now, the technique that I will describe is called the push smear technique. There's a number of techniques to making a smear, but this is the one that's most commonly used. Then we'll also talk a little bit about, after you make your smear, quick drying the smear to reduce artifacts. And then we'll talk about how to stain your preparation before we talk about how to evaluate it. Here we're illustrating a push smear technique. You can see the arrow is pointing toward a very small drop of blood on the slide. Notice that the drop is very little in comparison to the diameter of the slide. And when you place your drop of blood on the slide, you want to make sure that you maintain a small drop coming out, so that you don't have too much blood and the smear is not too thick. Then what we'll do is we'll back up a second slide at a 45-degree angle until the rear surface of this slide touches the drop of blood. When it does, the blood drop will start to diffuse along the surface of the slide, and as it starts to diffuse out, before it gets to the end, you will gently slide the top slide forward, and you will make a smear, as you can partially see here in this particular slide in the back, on your slide. Now, once this smear is made, you'll want to rapidly dry the slide using a blow dryer. Now, here we have a blow dryer that's on a stand specifically made to dry blood films, but you can use any hair dryer that you can purchase at a department store for this purpose. You may just have to hang it on a nail or use another type of stand to mount it. The slide should be held approximately 8 to 12 inches away from the air, and you can use warm air, and you should use warm air to rapidly dry your blood smear. This will reduce artifacts, which are real important in reducing artifacts when you're evaluating the slide for morphologic changes in cells. Okay, so this is a very important step of our slide preparation. Then, if we can have the next slide, we'll talk about staining. The basic stain that we'll use in hematology is the diff-quick stain. That's the one that we'll routinely use for evaluation of blood smear. In addition to that, though, you would also want to have a new methylene blue stain available. And although we don't use that routinely, this particular stain is used for two circumstances. One is reticulocyte stain, and the other is new methylene blue staining for Heinz bodies, which we'll talk about in just a couple of minutes. Okay, so the first thing we'll talk about is the diff-quick stain, which is our routine stain that we use, and which most of the slides that you'll be viewing here today will be stained with. Okay, so here's a set of diff-quick stain. All the way to your left, you see this pale blue staining solution. This is actually the fixative. The slide is first placed in the jaw with the fixative for approximately 2 minutes. Then after you come out of the fixative, you just dab off the excess material, and then we'll place it in the eosinophilic stain in the center here, and we'll do 8 to 10 1-second dips in the eosinophilic stain. Then we'll go to the basophilic stain, and we'll do 5 to 6 1-second dips in the basophilic stain. Now we'll do less time in the basophilic stain because Diff Quick tends to overstain the slide blue, and we don't want that. We're evaluating red blood cells, so we want to have a little more of a red tint to our slide. And that's the method that most of these slides you'll be viewing has been stained with. Okay? Let's briefly run over the procedure for evaluating a blood film. The very first thing that we'll want to do is we'll want to place the slide on a microscope and then scan the entire slide at a low magnification, usually a 20x magnification. We're scanning the slide to look for certain things that we can see even from a low magnification. One, we want to know what's our predominant leukocyte. Is it the neutrophil, which it should be in most of our domestic species, the dog and the cat and the horse? Or in the ruminant species, such as the cow, it would be the lymphocyte, our predominant leukocyte. Then we want to know what's the arrangement of our erythrocytes. Are they a nice, even single layer of cells, or are they clumped together and arranged in certain patterns that we'll discuss? Then we'll evaluate for platelet clumps and any abnormal cells in circulation, meaning cells that we don't normally find in patients' blood, such as nucleated red blood cells, or any reactive or left-shifted or neoplastic leukocytes that we might find in circulation. All this can be seen from a low magnification. Once that's done and we've scanned the slide, just trying to recognize any major gross abnormalities, then we'll go down to a 100x oil magnification. And we will systematically evaluate all 3 of our blood cell types, one at a time. I personally like to do the erythrocyte evaluation first, so I look at the erythrocyte morphology. Then we'll look at the platelet numbers. We can estimate them from the smear and morphology. And then finally, we'll look at leukocyte numbers and morphology. And I do those last because we have a tendency when evaluating peripheral blood to want to put a slide on the microscope and immediately start doing a differential leukocyte count. To avoid that, I like to do the other cell types first. And again, we're looking for morphologic changes. Look for morphologic changes in red cells, then platelets, and then finally we'll go to our leukocytes and do a differential count and look for any changes or abnormalities in morphology with the final cell type. So let's go ahead and get started looking at some blood films, and we'll describe this technique as we go along. The first thing we'll want to do is we'll want to look at erythrocytes. Okay? We'll do an erythrocyte evaluation, again, using our 100x oil magnification. And we specifically are looking for changes in morphology. We're looking for changes in size, shape, or color of the erythrocytes. And if we have any abnormalities present in the erythrocyte cell line, we'll want to do a specific evaluation for hemoparasites. Okay? So here's our first slide. This is normal canine blood. Notice that the cells are evenly dispersed throughout the blood smear. And in addition to that, you'll see that the cells are all approximately the same size and shape. The arrows are pointing to normal canine red blood cells, but of course all of the cells here are normal. One thing I would like you to notice about these cells, in addition to being all the same size and shape, they're all approximately the same color. No variation in cell color. And they have a central area that's pale. These cells are disc-shaped when you're looking at them in a 3-dimensional view. And the center doesn't have hemoglobin. Now this central part is called the central pallor, and it's an important part of the canine erythrocyte. And it should equal to about 1/3 of the diameter of the cell. Okay? So if you're looking at the diameter of a red blood cell in the dog, you would see 1/3 hemoglobin. 1/3 central pallor, another third hemoglobin as you go across the cell surface. Okay, an important aspect of the canine erythrocyte. Now here we have normal feline blood. The arrows are indicating to you rouleau, which is a coin-like stacking of erythrocytes. A small amount of rouleau is normal in the feline blood. Also notice that the feline blood cells, not all of them have a central pallor, as the canine erythrocytes do. That's important because in the canine we can detect spherocytes, which are small cells with no central pallor. But in other species we cannot, because it's normal for other species to not have a central pallor. And again, the characteristic feature of feline blood is the presence of a small amount of rouleau. Normal equine blood seen here also has a small amount of rouleau that is present, which is this coin-like stacking of erythrocytes. That's normal in the equine red blood cell. And very much like the feline red blood cell, sometimes a central pallor is not visible in these particular cells. Only in the canine do we consistently have a large central pallor like we see here in this equine red blood cell. Okay, one of the things we'll want to do from a scanning objective is we'll want to look at the arrangement of the red blood cells. One thing we already mentioned was the formation of rouleau, which is a coin-like stacking of erythrocytes, as indicated here. Sometimes it's difficult to tell whether we have rouleau present in a blood smear or agglutination, which is a clumping of the red blood cells. Now there's a difference because rouleau is caused normal, a slight amount is normal in the feline and equine blood, but excessive amounts of rouleau is caused by increased amounts of protein present in your blood. For example, acute phase inflammatory proteins like fibrinogen become elevated in animals' blood when they become sick. And then we get rouleau formation. Agglutination is much different. Agglutination is the result of antibodies that are directed against the red cell surfaces that bridge the red cells and pull them together in a cluster. And we see this in immune-mediated diseases. Well, sometimes rouleau can be excessive, as we see in this particular blood smear, and you can't really tell, is this just excessive rouleau or is it agglutination? And we have a test that we can do to distinguish between these two, and it's called the saline test. In the saline test, we take a 1/2 ml of saline, and to that saline, physiological saline, we add a single drop of blood. Now, if it's rouleau, the blood will be dispersed in the saline because you're diluting the protein. If it's true agglutination, the clumps of erythrocytes will still be present because no matter how much saline you use, you cannot dilute the antibody-mediated clumping that occurs with agglutination. So we put a drop of blood into a 1/2 ml of saline, and then we put that on a microscope slide. Put the drop of blood and saline mixture on a microscope slide. We cover slip it and examine it unstained on the microscope. Microscopically, if we see the cells individualized, we know that it's the result of rouleau because we've now dispersed the rouleau in this diluted sample. If it's true agglutination, you will not see individualized cells, but you will see clusters of cells under the microscope because you cannot dilute the antibody-mediated reaction of agglutination. And that's called the saline test. Okay? Before we start looking at erythrocyte changes in the blood, I want to try to describe to you the development that occurs in the bone marrow of the erythrocytes. All the way to the left, you can see the rubroblast, which is the most immature form that we can recognize in the bone marrow. You will not normally see these cells in the peripheral blood. The rubroblast has a very large nucleus, and it has a fairly abundant, deeply basophilic cytoplasm. As the cell matures in the bone marrow, the nucleus becomes smaller and smaller until it becomes pycnotic and dies. Before it is released from the bone marrow, in normal circumstances, this nucleus is extruded out of the cell, and we wind up with the mature erythrocyte seen all the way over here on your right. So the cell becomes smaller, and the nucleus becomes smaller, and eventually it's extruded from the cell completely. The cytoplasm of the ruboblast and the very immature erythrocytes is deeply basophilic because there's so much RNA material inside the cytoplasm. It stains deep blue. As the cell matures, the RNA is replaced by hemoglobin. And the hemoglobin gives the red blood cell its orange color. So as the cell starts to mature, the cytoplasm becomes less basophilic and more eosinophilic, or orange in color, till a mature erythrocyte has the maximum amount of hemoglobin that it needs. Okay? So it goes from blue to more eosinophilic or orange in color as the hemoglobin gets concentrated in the cytoplasm. Okay? A little bit about erythrocyte development. Now here's a blood film from an animal that it has a severe anemia. Okay? So this animal is severely anemic, and we can see a number of changes in these particular cells in this patient. One thing we mentioned before is that normal red blood cells should all be about the same size. Here, if we look at these red blood cells, we would see that this would be approximately the size of your normal red blood cells, with a central pallor that's equal to about 1/3 of the diameter of the cell. And this is canine blood. So we know that's a normal cell. We have some cells that are larger than normal, and some cells that are smaller than normal. This variation in cell size is called anisokaryosis. That's ANISOKARYOSIS. Anisokaryosis, or variation in cell size. These larger cells that we see, excuse me, let me back up to my previous slide. These larger cells that we see are less mature erythrocytes. Remember, the red blood cells get smaller as they mature. So these larger cells that we see here are the less mature erythrocytes. They're immature red blood cells. Notice also that the central pallor has been distorted in these cells, and we'll talk about why in a minute. So these animals with less mature cells are producing these cells rapidly and kicking them out of the bone marrow before they're fully mature. These smaller cells that we see here, notice, are very dark and they have no central pallor. These are spherocytes. These red blood cells are smaller in diameter than your normal red cell, and they are seen again in patients that have immune-mediated hemolytic anemia, which is the problem that this patient had here. So the recognition of spherocytes in the peripheral blood is a very significant finding and allows us to diagnose immune-mediated hemolytic anemia in this patient. So again, we have anisokaryosis with large red blood cells and small red blood cells. So that's variation in cell size. Let's talk a little bit about variation in cell shape. Here in figure A, we have what we call a reticulocyte, or an immature red blood cell. Notice it has excessive red cell membrane. And when we viewed on the previous slide the distorted central pallor of these cells, we can see why. Because it's no longer a disc shape. It's kind of a knobby appearance, and it distorts the central pallor. Here in frame B, C, and D, we have projections coming out from the red blood cell surface. Now this is an EM, a scanning electron micrograph of the red blood cell. Here we have these projections that come up from the surface, but notice they're all about the same size, and they're evenly distributed around the cell. That's crenation. It's an abnormal shape of red blood cell that we find in the peripheral blood of some patients, and we'll discuss why in just a second. This particular cell is also abnormally shaped with projections coming out, but they're irregular. They're varying in size, they're varying in shape, and also they're not evenly dispersed around the red cell membrane. And these are acanthocytes. This is a true pathologic change in a red blood cell that's occurred because of a disease condition in the animal, whereas crenation can be artifact. Okay, and we'll talk about that in just a moment. Here's a peripheral blood smear. This happens to be from a pig. One of the problems with pig blood that we see routinely is that their cells crenate very easily. And so we routinely see crenation in the pig blood. This can occur in any species of animal when the red blood cells sit in a tube too long and ATP energy is depleted. The cells can't maintain their normal shape and they start to crenate. So this is usually an artifact of with sample collection and slide preparation, not a pathologic condition in the patient. And notice how in crenation there's a large number of projections that are kind of evenly spaced and distributed around the cell surface. Okay? That's in crenated red blood cells, usually an artifact. Now in this particular blood film from a cat, we can see that yes, there are irregularly shaped cells, but projections are not evenly dispersed around the cell membrane. In fact, they're very irregular in the way that they protrude out of the red blood cells. And these are called acanthocytes. Now, acanthocytes are a true pathologic condition that we find in animals. They result from an abnormal phospholipid and cholesterol content in the red cell membrane, often seen in patients with liver disease. Now, this particular cat had hepatic lipidosis, and we can see severe acanthocyte formation in cats with hepatic lipidosis. Because naturally, these animals, because of the high lipid content in their liver, not only do they have liver disease, they have an abnormality in lipid metabolism that's occurring. So we get alterations in the phospholipid and cholesterol content in the red cell membrane, and we get acanthocytes forming. We can also get acanthocytes forming in patients with certain tumors, specifically hemangiosarcomas. Sometimes they'll involve the liver, sometimes not, but we can see acanthocyte formation in patients with that particular type of a tumor. Okay. Another abnormal shape that we can find in the red blood cells is the presence of schistocytes. Now that is a very small fragment of a red blood cell. Notice they have, again, irregular projections, but the size of this cell is very small compared to what a normal red blood cell size would be. The schistocyte is a specific type of red cell abnormality that results from a fragmentation of the red blood cell. The red blood cell is cut and fragmented as it goes through abnormal vasculature, and then it reseals again in the smaller size, and we find these schistocytes in circulation. So what that tells us is that we have an abnormal vasculature occurring, usually associated with thromboembolic disease or DIC, disseminated intravascular coagulation, where we have fibrin forming in blood vessels, and these fibrin strands would cut our red blood cells, forming schistocytes. This particular patient was in DIC, and the hematologic findings that we see in this particular smear are classic for patients with DIC. One, we have an anemia. Two, and we haven't gotten to it yet, but in the background there are no platelets observed. So this animal is thrombocytopenic, and we'll talk about that in a few moments. And we have evidence of red cell regeneration with bluer-shaped red blood cells and nucleated red blood cells out in the peripheral blood, indicating the bone marrow is throwing out these cells into peripheral circulation faster than it normally would. Okay, so classic hematologic findings in disseminated intravascular coagulation. So we talked about changes in size of red blood cells. We talked about changes in shape of red blood cells. And now we talk about changes in color of red blood cells. Remember, we said that when red blood cells mature, they lose their cytoplasmic basophilia as they gain more hemoglobin until they get to finally a mature state where they're orange, like here and here. So if we have immature red blood cells, which indicates a regenerative response in the peripheral blood, we would expect these immature cells to be more basophilic in color. And they're called polychromatophilic cells or reticulocytes, the terms used to describe these immature red blood cells. And we see them in an anemia that's regenerative. In other words, the patient is anemic, but it is regenerating new blood cells from the bone marrow, either resulting from a blood loss anemia or hemolytic anemia, but the patient is able to produce new red cells. And that's what these arrows indicate, the immature polychromatophilic cells that we see. This is the only thing that we use as an indication of regenerative response, is the presence of polychromatophilic cells or reticulocytes in the peripheral blood. Now this will give us kind of a qualitative analysis of regeneration, the presence of finding reticulocytes or polychromatophilic cells. If we actually want to quantitate the degree of a regenerative response in the peripheral blood, that's when we would use our new methylene blue stain. Here, we'd take a drop of blood, and we would add to this drop of blood a drop of new methylene blue stain in a test tube. Okay? We let that sit for 10 or 15 minutes. Then this mixture of new methylene blue and blood would be taken out of the tube. A very small drop would be added to our slide, and we'd make a blood smear using this mixture of stain and blood. Now we're ready to evaluate this at 100x, and we will actually count the number of reticulocytes present as a percentage of the total number of mature red blood cells. For example, here we have a new methylene blue stain doing a reticulocyte count. If you look here, these would be normal red blood cells. They have just a homogeneous blue staining appearance. Some of the red blood cells have small blue specks on them. These are the reticulocytes. Now in the dog, we only have one type of reticulocyte. So we would just go along and count normal, normal reticulocyte, normal reticulocyte, normal reticulocyte. And we get a percentage of red cells that are reticulocytes. And we'd like them to be over 1% of the cell population before we determine that to be a regenerative response. In cats, as we see here in the cat blood, they have a particular difference in their reticulocytes than any other species. They have two types of reticulocytes. They have what we call an aggregate reticulocytes, where they have clumps of reticulum, which is this blue staining material, and they have the punctate reticulocytes, which is just individual specks of the blue staining material, as we see down in the lower right-hand corner. The ones that we want to count in the cat, and the ones that have a more significant finding of a regenerative response, are the aggregate reticulocytes. And we would like them to be over 1% of the cell population. Okay? Now there's a small calculation that needs to be made once you have a percentage figured out from your blood smear itself. And this is what you need to do, is you use a formula to correct for the number of reticulocytes that you have with the degree of anemia that the patient has. And we use a ratio of your patient's PCV, or packed cell volume, as your numerator, and normal packed cell volume for that species. Say, for example, the dog is 45, as your denominator. So you have a ratio of your patient's PCV over normal PCV. For a dog, say if you had an animal that had a 20 PCV, you would put 20 over 45. Now with that fraction, you would multiply that times the percentage of reticulocytes you counted from your peripheral blood smear. And you would alter that percentage by the multiplying it times the fraction. For example, if you counted 5% reticulocytes on your peripheral blood smear, and you had a patient that had a hematocrit of 20, you would make as a fraction 20 over 45 and multiply that times 5%. Now multiplying 5% by 20 over 45 would approximately half the amount of reticulocytes that you counted, down to approximately 2, maybe 2.2% retics. So you would adjust your reticulocyte count depending on the degree of anemia that your patient has. And if it's over 1%, once you've corrected your reticulocyte count, then the anemia is regenerative. And that's how we do a quantitative analysis of regenerative response in a patient's blood. Let's talk about another change in color that can be commonly seen in a peripheral blood of patients, and it's called hypochromasia. We determine that a patient has hypochromic red blood cells when the central pallor, and this is in dog blood, is more than half the diameter of the cell. What this indicates is that the patient has a decreased amount of hemoglobin present. Hemoglobin is the orange color staining in our blood cells. And when it is reduced in the red cells, we see these hypochromic cells. This is most often seen in animals that have iron deficiency. And usually patients that are iron deficient, like we see here in this particular animal's blood, have had chronic blood loss, either associated with external parasites like fleas or ticks, internal parasites like hookworms or some other type of intestinal parasites that we can get in these patients, or just chronic bleeding or hemorrhage from any surface at all. It could be in the urinary tract, GI tumors, a number of cases where we can have hemorrhage over a long period of time and become iron deficient. And you will see that in these patients' blood because they will be hypochromic. Okay, so we talked about changes in size, we talked about changes in shape, we talked about changes in color of red cells. Now let's talk about inclusions in erythrocytes. This is cat blood, and you notice the arrows are pointing to these knob-like protrusions on the red cell surface, or sometimes these pale, very pale spots that you might be able to visualize on your screen inside the red cell. These protrusions and these pale spots are called Heinz bodies. Now, Heinz bodies are denatured parts of the hemoglobin molecule, denatured globin parts of the hemoglobin molecule in these animals, and it occurs when you have oxidative damage to these molecules. Now, the cat blood is particularly susceptible to Heinz body formation because of the large numbers of sulfhydryl groups that are present on their hemoglobin molecule. The cat has 8 sulfhydryl groups on the hemoglobin molecule, much more than any other species, so they have a very high tendency to develop Heinz bodies, as we see here in this peripheral blood. Although the Heinz bodies do develop, the cats are very tolerant of these Heinz bodies. Its spleen, unlike other species of spleen, does not have sinusoids that will remove these Heinz bodies from circulation, so they tolerate them much better. Other patients with this many Heinz bodies would develop a severe anemia. Any condition that causes oxidative damage to the red cells will cause these Heinz bodies to form. They may be associated with administration of Tylenol to animals, and this is one reason that Tylenol gets cats so sick, large numbers of Heinz body formation. Other oxidant damage can occur as a result of eating certain plants that can cause oxidative damage to the red blood cells. In addition, onions will cause it as well. And large amounts of onions ingested into some patients will do that. Some baby foods that people will want to feed their sick cats, sometimes they give them turkey or ham-based baby foods. There's onion powder in it, will cause Heinz body formation. And there are specific diseases in the cat, since they're so susceptible to Heinz body. There's 3 specific diseases that can result in large numbers of Heinz bodies in the cat. Hyperthyroidism, lymphoma, and diabetes mellitus can all result in Heinz body formation in the cat. So when we see these Heinz bodies forming in animals, we need to think about these conditions as possible etiologies to cause them to form. Now, if you suspect Heinz bodies but you're not sure and you want to confirm their presence, again, we would use new methylene blue stain. Here, just like with your reticulocyte stain, you would mix blood with new methylene blue, put a drop on the slide, and this is what you would see. Here are our mature erythrocytes, and you'd see these Heinz bodies stained dark blue with new methylene blue stain, easily recognized using this stain preparation. Okay, so it's another use for new methylene blue stain in our practice. whereas most of the time we're using the diff quick stain. Okay, let's talk about some other inclusions that we can find in erythrocytes. Now this is again not a new methylene blue stain, this is a diff quick stain, and we can see these dark black inclusions that are around that are found on these two erythrocytes. These are called Howell-Jolly bodies. Howell-Jolly bodies are nuclear remnants that are left in the red cells when the nucleus is being extruded in the bone marrow. Normally this happens, these cells come out into circulation, and we will find these Howell-Jolly bodies in the peripheral blood. But the spleen removes them very quickly, so we hardly ever find them. Less than 1% of the erythrocytes would have them. If we see increased numbers of Howell-Jolly bodies in the peripheral blood, that would indicate to us that either large numbers are coming out of the bone marrow as a regenerative response to an anemia, or something's wrong with the spleen. So those are the two things that we need to think about when we see increased numbers of Howell-Jolly bodies in the peripheral blood. One, we see them in a regenerative response, or two, we have a problem with the spleen, and although they're coming out in normal numbers, the spleen is not extracting them. Maybe it has a tumor. Also, if you give an animal steroids, corticosteroids, decreases the phagocytic functioning of the spleen, and you'll find these increased numbers of Howell-Jolly bodies in the peripheral blood. Okay? They stay nice, dark, black, and round with regular diff quick stain. This is a nucleated red blood cell that we can find in the peripheral blood of patients that have a regenerative response, although we do not use nucleated red blood cells to determine whether an anemia is regenerative or not. The reason is we can find nucleated red blood cells in conditions that are not regenerative anemias, okay? So we really only use reticulocytes to determine if anemia is regenerative, but we will see these nucleated red blood cells in a regenerative anemia. Now this is cat blood. This cat is anemic. We can see we have polychromatophilic cells present, indicating truly it is regenerative. These reticulocytes are polychromatophilic cells. And the reason this patient is anemic is because it has these dust-like small inclusions on the cells. These are Hemabartonella felis organisms that are present on the feline erythrocytes. I'm going to point some other cells out with the pointer. You can see these very small inclusions in focus with the red cell membrane. These are all Hemabartonella felis organisms. They're very small, and you have to look very carefully to find them in the peripheral blood. And that's why, another reason why we can't have artifacts in our blood smear. If we have stain debris or drying artifacts, you will not be able to visualize these little small hemoparasites that are present in this particular cat. Okay? Hemabartonella felis. This is a scanning electron micrograph of what these organisms look like. You can see that they indent the red cell membrane, and they leave these little pock-like inclusions. Now these cells will be destroyed and removed by the reticular endothelial system in the patients, and they develop severe anemia associated with an infection of Hemabartonella felis. They can be individualized, or as we see down here at the bottom, they can be in chains on the organisms on the red cell membrane. Okay, so that's the EM of what these organisms look like. Just for size comparison, because often people confuse Hemabartonella felis with Howell-Jolly bodies. I have a picture here of a Howell-Jolly body and in a cat that's infected with Hemabartonella felis. And you can see that the Howell-Jolly body is much larger and darker staining than these smaller Hemabartonella felis organisms that are seen in this patient's red blood cells. I wish these organisms were as easy to see as Howell-Jolly bodies. Again, these are nuclear remnants. These are hemoparasites. Another hemoparasite that we see here in Florida in particular, also in other areas of the country, but in particular Florida, this is Cytoxoan felis. Unlike Hemabartonella, which is a bacteria, Cytoxoan felis is a protozoal hemoparasite that infects the red blood cells of cats. You can see this protozoal organism has a nucleus and a cytoplasm, and they form what we call a signet ring formation. It kind of looks like a ring shape if this would be the stone and that would be the rest of the ring. So they're called a signet ring formation. This is a severe disease. It is tick transmitted, and we see this in domestic cats. Very high mortality associated with disease. Most of the time, by the time the patients present to you, there's significant numbers of parasites in the blood, and these patients are critically ill. They can be treated if you catch this quickly enough. So it's important that you recognize this disease in the peripheral blood of these patients so that you can start immediate therapy with imidacloprid, which is a treatment of choice currently being used to treat this disease. This is an interesting disease, and one reason that we see this in this area of the country is that these particular parasites are found in our wild cat population. Now, they cause inapparent infections in the Florida panther and the bobcats, but if this organism is introduced into a domestic cat, it causes severe disease with a very high mortality. So we see this particularly in rural areas where we have an intermingling of domestic cats in areas where they have a wild cat population. And we also see it in other areas of the country where we have cougars and panthers and bobcats that can come up to areas of development where we have a domestic cat population as well. And again, they don't need direct contact with these wildcats. It's tick transmitted, so it just needs to have a tick bite a wild cat that is infected with this organism. And again, they cause inapparent infections in most of these wildcats. They aren't sick. They pick up the organism. The tick then feeds on one of the domestic cats in the area, transmits the organism, and then we have severe clinical disease and often death in these particular animals. Cytoxoan felis. Now, if we look at this next slide, this is canine blood. Another inclusion here. This is Hemabartonella canis, the counterpart to the bacterial hemoparasite that we find in the cat is Hemabartonella canis in the dog. Characteristically, though, this organism always forms chains on the red cells, and they're very easy to recognize. Unlike Hemabartonella felis in the cat, Hemabartonella canis doesn't cause clinical disease in all animals. Only if the animal is immunosuppressed or has been splenectomized, as this dog has been splenectomized, and that's why we see the Hemabartonella canis in the peripheral blood. Hemabartonella canis will not cause clinical disease in a normal dog. Now, Hemabartonella felis will cause clinical disease in a normal cat, but not canis in the dog. And it's easy to recognize this organism because of its characteristic chain formation on the red blood cell surfaces. Here's another parasite very common to Florida. This is Babesia canis. It, again, is a protozoal organism that has a nucleus and a cytoplasm. Unlike the bacterial infection, Hemabartonella canis, this is in dogs. This organism, Babesia canis, causes most severe disease in puppies. It is, again, tick transmitted just like our other protozoal disease, causes most severe disease in puppies. In adult dogs, mostly are inapparent carriers. Okay, so that's all for our red cell evaluation. I wanted to point out a number of different changes in size, shape, and color that we can see in the red cells, as well as inclusions. Now, once we've done a red cell evaluation, then we'll move on to platelet evaluation. Here, one thing we want to do is we want to scan the slide looking for platelet clumps. The reason we do that is because if we have platelet clumping present on our smear, we cannot accurately estimate platelet numbers, which is one of the things that we do when we're evaluating platelets. We just have to assume that they're normal if we have platelet clumps. The way we estimate platelet numbers is by looking at the number of platelets per 100x oil field, and we multiply it times 15,000 if it's a dog, 20,000 if it's a cat, and we use that number as the number of cells per microliter. And normally it would be over 200,000 in the dog and the cat, over 100,000 in the horse and the cow, and we use 15,000 as a number to multiply our cells by with all species except the cat, really, which is 20,000. Okay? After we've done that, then we'll do an evaluation of platelet size, And here, if we're looking specifically for large platelets, which are called megaplatelets. Okay, so let's look at a peripheral blood smear and see if we can identify these changes. Here we have a blood smear from the dog, and these arrows are indicating to you platelet clumps. Now, when these platelets are clumped together, we have to assume that our cell count is going to be normal, that we have sufficient numbers of platelets in the peripheral blood. Because we might go to areas of the slide and try to evaluate areas where there are no platelets and do a count that would look like it's falsely reduced. So since many of them aren't dispersed but clumped in little piles, we assume the platelets are normal at that point. Here's a peripheral blood smear from an animal. You can see this patient has no platelets in the background. When we have no platelets, we call it a thrombocytopenia, and this patient had a severe thrombocytopenia, lack of platelet production. Excuse me. As a result of that, when you have no platelets, since it's the platelets' function to maintain blood vessel integrity, you can bleed from your blood vessels spontaneously when you don't have sufficient platelets. This patient was bleeding spontaneously into the GI tract for a long period of time, and as a result, developed hypochromasia in the red blood cells. Remember, we talked about hypochromasia as being a central pallor that's over half the red cell diameter. So here we have a severe thrombocytopenia in this patient, and we can tell, again, we have hypochromasia in the red cell line from chronic blood loss and iron deficiency. We can tell that from the blood smear. Okay? Whenever we have platelets that are larger than the red blood cells themselves, we call those megaplatelets. And they are an indication to us that the patient has increased demand for platelet production in the peripheral blood. And he's throwing out larger, more immature-looking platelets in the peripheral blood. So even though the platelet count may be normal, if you see giant platelets in the peripheral blood, it indicates an increased demand for them in the periphery. Okay? So basically, our platelet evaluation involves two things. One, a platelet count estimation, and a platelet size evaluation. And there's one other thing that I want to show you in platelets, and it's a specific parasite that we can find in platelets. It's kind of an interesting finding and not uncommon. This is a blood smear from a dog. Actually, this is from one of our previous graduates sent me this blood smear, who's working down in Miami. Very common problem down in that area. This is a dog that came in loaded with ticks. And a graduate from our school who's working down there found these organisms in the red blood cells, the Babesia canis organisms that we saw before. But in addition to that, when she sent the blood up here for us to evaluate, we also found something else. Notice this patient is thrombocytopenic. Here's a platelet right here. But inside this platelet, there's a smaller dark inclusion. Hopefully you can visualize that on your screen. A smaller dark round inclusion. That is Ehrlichia platus. It's an organism that actually infects platelets and causes thrombocytopenia in these patients. Again, a tick-transmitted disease. And what we're coming to find now is that not only can ticks transmit one disease, but we're finding that many ticks are multiply infected with different organisms. So it's very common for us to get multiple infection of tick-transmitted diseases in patients with tick infestations. Okay, and this is an example of that in this one particular dog. Okay, so now we've done our platelet evaluation, and the last thing that we'll want to do is we'll want to do a leukocyte evaluation. Here, we can estimate leukocyte numbers if you'd like, which means that really you can get a total white blood cell count from your peripheral smear without having to wait for your results to come back from your automated hematology analyzer that may be present in your lab where you send your bloods to. So what we want to do to estimate a leukocyte count is we want to count the number of leukocytes now per 100x field, and we want to multiply that number times 10,000, and that will give us a total of cells per microliter. Now, typically, in most of our species, a normal leukocyte count will be approximately 10,000. So what you should really see is one leukocyte per 100x field. So if you look at a patient's blood and you have 3 or 4 leukocytes in every field, you know that patient has a leukocytosis. If you look at a patient's blood and you see that you hardly have any leukocytes, you might go through 3 or 4 fields before you might find one leukocyte, then you know that that animal is leukopenic. So it's a good way for us to estimate leukocyte numbers in our patients. Okay, now after we've done that, we can do a differential leukocyte count, which means we would tell what type of leukocytes are present, which ones are neutrophils, how many monocytes, how many lymphocytes, are there any eosinophils, basophils present, the different leukocyte types we have. And then importantly, we'll want to do a morphologic evaluation of our leukocytes. And here we'll be looking for these particular changes. One, we'll look for left shifting or immature leukocytes. We'll want to look for toxicity, reactivity, and neoplastic changes. And that's what we're going to discuss here in the final segment of this session. Let's go over some normal leukocytes in our different species, okay? Just to kind of orient you to what is the normal leukocyte population. This is canine blood, and we can see here we're illustrating neutrophils as having a dark segmented nucleus and a clear cytoplasm. These are the predominant leukocyte type in blood from most of our domestic species, would be the neutrophil. They would predominate. In the ruminant species, the cow in particular, the lymphocyte predominates. But in most of our domestic species, the neutrophils predominate. In addition to this neutrophil, we see this larger leukocyte on the left. Notice that the cytoplasm is slightly basophilic in this cell. And also notice that it's a larger cell with a bigger nucleus and a paler staining chromatin pattern. So that's the characteristics of the monocyte. Although it's lobulated, it's not completely segmented like a neutrophil, and it has a paler staining chromatin pattern in the nucleus. Okay, the monocyte. Canine blood again. Here we have a monocyte with a lobulated nucleus, light blue cytoplasm. And up here on the right-hand corner, we have a lymphocyte, which really has a round to maybe slightly indented nucleus with a scant amount of cytoplasm. Okay? So we have a lymphocyte, monocyte, and neutrophil. And the other 2 leukocyte types that we have in our species, and this is just illustrated in the canine blood, are the canine basophil and eosinophil. Now these are 2 granulocytes just like the neutrophil, except the cytoplasm has granules in them. The neutrophil would have a clear cytoplasm, although the nucleus would be similar. But in the eosinophil, we have variably shaped orange-colored granules, much the same color as our red blood cell. And in the basophil, we have a gray cytoplasm with smaller, darker, more basophilic granules. Now these cells are usually seen in very low numbers in the peripheral blood of our animal species. In fact, it's hardly ever see basophils unless we have a problem, usually associated with allergic hypersensitivity reactions or parasites. Same thing with eosinophils. Increased numbers associated with allergic hypersensitivity problem or parasites. Here we have feline blood, and now the lymphocytes and the monocytes are usually the same for all the species that we evaluate, but there is a slight variation in the basophil and eosinophil, and that's why we'll go over those. The neutrophil is pretty much the same for all the species. Nice dark segmented nucleus, clear cytoplasm. The eosinophil in the cat has a smaller, more densely populated granules, although they're smaller, but again, they're more eosinophilic than the basophil, which hardly has any granules. It does have a gray cytoplasm, though, and very faint, small granules in the cytoplasm, hard to visualize. Both of these cell types are larger than neutrophils, okay? Oh, let me back up for just a minute. This is equine blood. Again, we have rouleau formation on the red cells, which is normal in the horse. And in addition to that, the horse eosinophil is a very characteristic leukocyte because it has these large granules, almost raspberry-like in appearance, the horse eosinophil. Eosinophils and basophils are seen in horses and cats and dogs and other animals in increased numbers for the same reason in dog allergic hypersensitivity problems or parasites. Let's look at leukocyte development so we can discuss some of the changes that occur in these particular cells. Over here on the top row, we just have a schematic of the nucleus developing in the leukocytes. The nucleus starts out large and round in the myeloblast, which is the most immature form of leukocyte that we can recognize in the bone marrow. These cells are normally only found in the bone marrow. As these cells mature, the nucleus gets smaller, starts to get indented, then is band-shaped, and then segmented. This is the development of the neutrophil. Okay? Round nucleus going all the way to segmented nucleus. If you look at the cell itself, the cytoplasm starts out basophilic and eventually clears in the mature neutrophil, whereas in the eosinophil and the basophil, it would contain granules. Okay? So it becomes segmented in nucleus, and the cytoplasm goes from basophilic to clear. Okay? That's how these cells develop in the bone marrow. Let's look at the peripheral blood of this particular dog. If you look at this animal, these are all neutrophils, but they're immature neutrophils. Here we have a banded neutrophil, where it's not quite segmented like the mature neutrophils that we looked at before. It's not completely pinched off in the center of the cell. Even more immature than the band neutrophil is the metamyelocyte, which is almost like a hot dog shaped, a thick, fat band, and that's less mature than the banded cell. And even less mature would be a myelocyte, which just has an indentation in there. Now, in this particular dog's blood, every cell, every neutrophil, and every granulocyte was left shifted. This animal did not have an infection. There was no toxicity. The cytoplasm is completely clear, and we'll talk about toxicity in a second. But what it did have was a congenital abnormality. Most common leukocyte congenital abnormality we have is called Pelger-Hewitt anomaly. It's P-E-L-G-E-R, capital H-U-E-T, Pelger-Hewitt anomaly, which again is an anomaly where these patients have leukocytes that do not mature. They just stop maturation at the band. So we see all of the neutrophils will be left shifted. This is a clinical finding that is usually seen on routine examination of the blood because these animals have no adverse effects from this condition. These neutrophils function normally. Let's talk about toxicity. Now, there's a little bit of confusion sometimes amongst veterinarians about what toxicity is and what cell types it occurs in and what it means. So hopefully we're going to clear that up here with you today. Toxicity is a cytoplasmic change that is only seen in neutrophils. We don't look for toxic changes in any other leukocyte but neutrophils. When we find toxicity or toxic change, what that indicates to us is that the animals have been exposed to some systemic toxin, usually caused by a bacterial infection, where toxins are released into the bloodstream of the patient, and we have damage or developmental arrest to the neutrophils in the bone marrow. So again, this is only a change that we find in neutrophils. The degree of toxicity that we see in these leukocytes will help us to determine the severity of the infection. And we grade toxicity as a 1+, a 2+, a 3+. And we're going to look at some of these changes and how we determine what's a 1+ toxicity and what's a 2+ toxicity and what's a 3+ toxicity. So let's take a look at our slide here, and we can see this particular animal has a mild or 1+ toxicity. And what we see in a patient with 1+ toxicity is no longer is the cytoplasm completely clear, but we have these small, irregular, basophilic inclusions in the neutrophil. These are called Dole bodies, and they would indicate a 1+ toxicity. Okay? This particular patient, now this is a banded neutrophil. Okay, so they had a left shifting present in here. This animal had a pyometria and a severe infection, was 2+ toxicity. where not only do we have Dole bodies in the cytoplasm, but the cytoplasm is diffusely basophilic. Okay, so that's a 2+ toxicity in this particular patient. And a more severe toxicity would be a 3+ toxicity, where we have Dole bodies, we have cytoplasmic basophilia that is diffuse, and we also have this clearing, these small vacuoles present in the cytoplasm. Now that would be a 3+ toxicity, and again would indicate a more severe bacterial infection than a patient with a 2+ or even a 1+ toxicity. Okay? So toxicity is cytoplasmic changes that we find in neutrophils, and only neutrophils. Okay? Here's another change that we can recognize, and again we're going over morphologic changes in these leukocytes. Here's another change that we can recognize in neutrophils, and this is called hypersegmentation. Now we talked about left shifting, where we don't have segments in the neutrophils, indicating that there's an increased demand in the peripheral blood for cells and immature cells in circulation. And here we have hypersegmented, just the opposite, where we have a nucleus of a neutrophil that has more than 5 segments. When the nucleus has more than 5 segments, we consider that hypersegmentation. That's an abnormality. This is an aged neutrophil in circulation. The most common cause of hypersegmentation in patients is administration of corticosteroids. And the reason we see hypersegmentation is that corticosteroids inhibits the migration of neutrophils out of blood vessels. The half-life of a neutrophil is only about 10 hours. Now, when you have an animal that's been given corticosteroids, you inhibit the normal migration of this cell. As it gets older, it will normally migrate out of the blood vessel in capillaries in the lungs. But corticosteroids inhibits this migration, so they age in circulation much longer, and they become hypersegmented. Okay, so it's the most common reason that we see hypersegmentation in the neutrophil. Okay. Here's another finding that we can see in blood, but this isn't really abnormal. I wanted to point it out only because it's common to see these. You can see that this particular neutrophil here, and this is horse blood. You can see all the rouleau present. We have an extension on a stalk of nuclear material, extension of nuclear material on a stalk, and that is called a bar body. A bar body is only seen in female animals. Okay? So any female animal can have bar bodies on their neutrophil, and the reason it's only seen in females is it's associated with the X chromosome, and the double X chromosome in females is what this bar body is associated with. So it's just a finding that we see normally in the peripheral blood of any of mammals that are female. Let's talk about what could be or is an abnormal inclusion. Now here's, again, equine blood. We have a little bit of rouleau formation. And what we see here is a neutrophil that has a round inclusion that is made up of small specks or dots. This is a bacterial infection. This is Ehrlichia equi. It's a granulocytic Ehrlichia in the horse. And a finding that we can see in patients that present with anemia, thrombocytopenia, and fever in these horses. And you can find Ehrlichia. Now, we mentioned the other Ehrlichia, Ehrlichia platus, in dog that occurs in the platelets. This is Ehrlichia equi, that's a granulocytic Ehrlichia that occurs in neutrophils. There are also monocytic Ehrlichias that infect monocytes. Ehrlichia canis is a monocytic Ehrlichia, but you will hardly ever find them in the peripheral blood. So that's why I do not have a picture of that here. You hardly ever see them. But you will find the granulocytic Ehrlichia, Ehrlichia equi in the peripheral blood. This is another organism that can be found in neutrophils, and this is in canine blood. This is Hepatozoan canis. It's a protozoal organism, unlike Ehrlichia, which is a bacteria. Protozoal organisms have a nucleus and a cytoplasm to the cell. Okay? Hepatozoan canis infection in the dog. Okay, let's move on to lymphocytes. Remember, we talked about toxicity in neutrophils and only in neutrophils. Now, we can recognize changes in other cells. but we call them reactive changes, and they do not indicate bacterial infection per se. They just indicate immune stimulation in general. It might be from bacterial infection. It could be from other types of infectious agents. It might be from neoplastic conditions, or it might even be from immune-mediated conditions like immune-mediated hemolytic anemia. Reactive changes can occur in lymphocytes and in monocytes. Here we're illustrating a reactive lymphocyte. What's different about this lymphocyte from a normal lymphocyte is the intensity of the basophilia in the cytoplasm. You can see that the cytoplasm of this particular lymphocyte is intensely basophilic, and most lymphocytes would have a pale basophilia in the cytoplasm. This is feline blood. Again, you can see rouleau. This is excessive amounts of rouleau. Normally, we don't see this much rouleau in a patient in feline blood, but the reason that we have this is that this animal has inflammatory disease, and remember, inflammation increases fibrinogen, and fibrinogen causes these red cells to be sticky, and you get rouleau formation in excess of what would be normal. Almost all of the erythrocytes here are in rouleau formation. This is a large monocyte in feline blood, and this is a reactive monocyte. Unlike the other monocytes that we showed in normal canine blood and feline blood, this monocyte is reactive. It has intensely basophilic cytoplasm and increased cytoplasmic vacuolation. Again, this means immune stimulation, usually of a chronic nature, but it's a non-specific finding to indicate there's some type of an inflammatory process going on in this patient. It might be the result of infectious disease, neoplastic disease, or immune-mediated disease. This happens to be from the peripheral blood of a cat that has Hemabartonella canis. Lastly, we'll want to talk about neoplastic cells. And finding them in circulation, of course, is a significant finding and means usually severe disease. These may be in the form of two different cell types. One could be non-hematopoietic cells in circulation, where we have cells, for example, that do not originate from the bone marrow and blood. It would be non-hematopoietic, cells that do not even occur in the blood. The most common example of that would be the finding of mast cells, M-A-S-T, mast cells in the peripheral blood of these patients. Or we can have really hematopoietic cells in the blood, but that are abnormal. They're blast cells, they're leukemic cells. And those are blood cells, but they're not normal blood cells, they're neoplastic cells. And we can recognize them because of their large size. They're usually 3 or more times the size of our normal mature red blood cell. They again would have increased cytoplasmic basophilia. Well, maybe you're saying this is really describing a reactive cell, and that's true if you only use those two criteria. But in addition to that, we have a very diffuse chromatin pattern in the nucleus, and the presence of nucleoli would also indicate to us that we have a neoplastic cell population, not a reactive cell population. So let's look at some of these non-hematopoietic and hematopoietic cells in circulation. Now here we have a peripheral blood from a cat. It's a blood smear from a cat. And then this cat had systemic mastocytosis. So what we have here are mast cells that are present in the peripheral blood. These cells have a round nucleus, but they have a cytoplasm that's full of these dark purple granules. They're not normal blood cells. So when we find these in circulation, we know that they're there because of a neoplastic process. So here we have a non-hematopoietic cell in circulation. Here we have a cat blood that has a leukemia. Now these cells that are pointing to blast cells, these are normal, well, no, they're not normal. These are cells that are blood cells, but they're very immature precursors that we would only normally see in the bone marrow. Finding them in the peripheral blood is an indication of a leukemia. Okay? In addition to these blast cells that are present in the peripheral blood, we notice that this patient also has nucleated red blood cells present. Now, nucleated red blood cells as a finding in the peripheral blood just might mean a regenerative response, except this patient has no reticulocytes, no polychromasia. And here we have, it's an abnormal finding in this leukemic animal. Notice also that in normal cat blood, we would expect the neutrophil to predominate, right? Remember we talked about looking for the predominant cell type and having that be the neutrophil. Well, here we don't have any neutrophil. Well, I'm sorry, we have one neutrophil present. Really, the predominant cell type are these large blast cells that we see in a peripheral circulation, much larger than red blood cells, with a diffuse chromatin pattern present, as well as nucleoli present in these cells, allowing us to identify them as leukemic cells in the peripheral circulation. And with that, I think I'm going to wrap up and summarize. In summary, the systematic evaluation of a blood film is the most important part of the hemogram. It's actually more important to evaluate the morphologic changes that are present in this peripheral blood than it is to look at the numbers with regard to leukocyte counts and erythrocyte counts. We can see that even from a peripheral blood, we can estimate the numbers that we will get from our CBC in the lab. So if you gave me a choice, would you rather look at a CBC from the lab or a peripheral blood smear? I would choose looking at a peripheral blood smear, because from that, not only will I gain the morphologic changes, I can estimate the counts that I need to from the peripheral blood smear itself. And it's always a good, handy thing to be able to do that, because sometimes we send blood off to the lab. It might be 24 or more hours before we get our results back. And here, looking at a peripheral blood smear, we can do that immediately in our private practice. All we need is some slides to make a smear and some stains to stain it with. And finally, the morphologic evaluation of the blood cells really yields clinically important information that we've discussed here today that cannot be obtained by any other laboratory testing. Meaning that when you look at the peripheral blood smear and you're looking at these morphologic changes present, you will not get that information from your CBC findings using an automated hematology analyzer. That's good news for us and good news for our technicians, because we know that we cannot completely rely on a machine to give us all the evaluation that we need to from a peripheral blood smear. So hopefully this has been helpful to you with regard to trying to incorporate the use of hematology in your veterinary practice, and a good review for you for your exam. And I look forward to speaking to you in person when you're viewing this tape, and we can have a conversation and answer any questions that you might have regarding the use of hematology in veterinary practice. Thank you for your attention.